Welcome to Holy Family Joint Class. Thank you for coming. My name is Tammy. I have been here at Holy Family for 21 years and nursing for over 26 years. This class was developed to help patients get ready, prepared, know what to expect after their joint replacement. It is a big undertaking, so we are trying to help you get ready, prepared, know what to expect after your joint replacement. I work in pre-admission testing 1 day a week. We do this class every Tuesday for all our joint replacement patients. I also work in surgical daycare. I work there 3 days a week, so I may see a lot of you when you come in for your surgery. So I'm going to start by going through the contents of the blue folder that everyone got. There's a pamphlet, Orthopedic Surgery. This is basically the class all in one. So everything I'm going to talk about today is in here. You can share this with your friends, family, anybody who wants to learn more about the class or your joint replacement and what to expect. We have a guide to managing pain. I will talk about this more in depth during the class, but it does go into our pain scale, descriptions of pain, just a little booklet that will help you prepare and be more ready for your surgery. We have a Speak Up pamphlet. If you see something, say something. If there are problems, issues while you are here, please let us know. We want you to have a good stay. We want you to be happy. Oftentimes people are afraid to report problems because they're afraid of retaliation. That's not what we want. We want you to have a good stay, be happy. We want you to come back. On the inside, there's a little checkoff list, just something, a little tool to help you. This will help you prepare for your surgery. Little checkoff box, preparing for surgery, at the hospital, after your surgery, so just a good little tool for you. We have another pamphlet on outpatient therapy. A lot of you may already have established outpatient therapy, but if you do not, we do have a facility here at Holy Family, 60 East Street, so we can help you set up appointments for that if need be. Little postcard that we made up for people. You can put this on the fridge wherever you like. Just a little to-do list before surgery, setting up your home prior to surgery, when to call the surgeon. On the back, it shows you kind of how the OR is set up, who's in there with you, making your own ice pack and staying active. So it's very important after surgery. You've got to get up and get moving. So just another little tool that we have given you. Everybody will get screened for staph before their surgery, so when you come into the lab, we are going to do a nasal swab for MRSA and staph, or MRSA. So anybody that comes back positive for either of these, we are going to call in a prescription to your pharmacy for two things. A mupirocin ointment that you will use twice a day, each nostril, not day of surgery. Day of surgery, we don't want you using any ointments, lotions, deodorants, any of those things. And then a Hibiclens scrub that you will use for 7 days, including day of surgery. Again, all the instructions are on here. If you come back positive, we know day of the swab, we will call and let you know, and we will let you know that we called in the prescription to your pharmacy. For every other patient that does not come back positive, we have in here pre-surgery Hibiclens instructions. So everybody will use it the evening before and morning of surgery. There are instructions in your folder on how to use that. Everyone gets a blue bottle of the Hibiclens scrub, and again, you're going to use that evening before and morning of. You're going to wash your hair with shampoo, your face and privates with soap. You don't want to use the Hibiclens scrub for the face and private area. It's very drying, very irritating. You want to make sure after your shower that you do not apply any ointments or lotions. You want to make sure you put on a clean pair or freshly laundered pair of pajamas, and you want a freshly laundered set of sheets on your bed the evening before. And again, every patient will use this evening prior to and morning of surgery. Follow these instructions. If you have any questions, you can call us in pre-admission testing. There is a paper in there about anesthesia. So this talks to you about the two types of anesthesia that will be offered to you, spinal versus general anesthesia. So this will help you get prepared for your discussion with anesthesia morning of. And again, I will go a little more in depth about this during the class. Most importantly, our surgical guidelines. So this you want to follow to a T, so your surgery goes off without a hitch. The first part talks about if you're taking an aspirin product, please discuss this with your surgeon. Some surgeons like you to continue your aspirin, some like you to stop 5 to 7 days prior to, so you want to make sure you discuss with your surgeon their preference. If you take anticoagulants, Coumadin, Plavix, Effient, any of those medications, again, you want to discuss with your surgeon and prescribing physician as to when and if you should stop those medications, if it's safe for you. Anti-inflammatory medications, so ibuprofen, Motrin, Advil, Aleve, any of those over-the-counter medications, you want to stop those 5 days prior to surgery. They thin the blood, increase the risk of bleeding, so we like you to stop those, again, the 5 days before. You're going to do the same thing with vitamins and herbal supplements, so any of those over-the-counter medications that you take extra, you're going to stop those, again, 5 days prior to surgery. They are not FDA approved. We don't know the effects they have on bleeding properties, so we just find it safer for you to stop those medications 5 days before. Tylenol or acetaminophen is okay to take, so you can use that prior to surgery. You want to make arrangements for a ride home. So those of you who are going home same day, make sure you have a ride in place. Our goal is to have you home and into the house before 6 p.m. For those of you staying overnight, the goal is typically to get patients out next day, usually 11 or after. So again, have a ride in place, someone that we can call when you're ready to go once physical therapy has given you the green light to go home. As far as arriving for day of surgery, the OR is going to call you the evening before your surgery. So if you are surgery on Monday, they're going to call you Friday afternoon between 3 and 7. Otherwise, they will call you the evening before to let you know time to be here. I'd like to tell patients that it can be anywhere from 2 to 4 hours prior to your scheduled procedure. A lot of the surgeons like their patients coming in 2 by 2, so you could be here, again, anywhere from 2 to 4 hours. So bring something with you to do. Your iPhone, iPad, Kindle, book to read, knitting, whatever it is you do in your downtime, bring something with you because you may have a little bit of time while you're waiting. You want to avoid shaving the surgical site at least 72 hours prior to surgery. We want to avoid any nicks, cuts, scrapes, any open areas near that surgical site. If you should have any, that could potentially cancel your surgery, so be very cautious. Nothing to eat or drink after midnight, so no lifesavers, no gum, no mints. The only thing you can have after midnight is water, and water freely. You can have it up until 2 hours prior to your scheduled procedure. So what I tell all my patients is by the time you're leaving the house, that's the time you stop the water, because typically we're having you come in at least 2 hours before your surgery. It's good to hydrate, so don't be afraid to drink some water. Have some water on board. It helps with preventing nausea, vomiting, helps prevent low blood pressure after surgery, so it will benefit you. Day before surgery, hydrate well. Have a good snack before you go to bed, something with a little protein, and that will help hold you over until your surgery time. On here, we're going to list medications we want you to take day of surgery. You could be on 20 different pills and we only have 5 on there. We have to pick and choose between your medications, which ones are safe to take. Some blood pressure medications can drop your pressure too low under anesthesia. Certain ones we want you to have, they help protect your heart. If you're diabetic and you take oral meds, you're taking those when you eat. You're not eating day of surgery, so we don't have them on there. The problem that I find that happens a lot is patients will come in for this class, or they'll watch this class and they get their instructions and they only see 5 pills on here, and that's all they take until time of surgery. That's not what we want you to do. This is just morning of. So up until day of surgery, take your regular medications like you would. You're just going to stop the vitamins, herbal supplements, and the ibuprofen or anti-inflammatory medications that you might take, whether it's prescription or over the counter. You want to bring a photo ID with you. Leave all valuables, jewelry at home. So only bring with you the things you will need while you were here. Electronics are okay, but again, your wallet, your credit cards, all those things, leave them at home. Jewelry, if it comes off, take it off, leave it at home. We don't want any metal on you when you are going into the OR. You could obtain burns. If you have rings on that you can't take off, you have swelling in that finger, we would have to use some ring cutters and cut the rings off. So the goal is, if it can come off, take them off, leave them at home. You're going to come au naturel day of surgery. You want to avoid any nail polish. It makes it very hard for us to get good readings of your oxygen level. If you smoke, it's best to quit smoking or cut down. Smoking affects circulation, delays healing. Alcohol is best to avoid 48 hours prior to surgery. Again, it can thin your blood, increase your risk of bleeding. For those of you that are going to be staying overnight, you want to pack a suitcase with 2 days worth of comfortable clothing. So sweatpants, yoga pants, pajama pants, something preferably with an elastic waist, no buttons, no zippers. It will make your life easier. You're going to have an assistive device, so whether it's cane, crutches, walker, you don't want to be fumbling with the zippers and buttons doing that. Plus you will have some swelling in that extremity, so you want to think about having some loose fitting clothing, no jeans, things like that. Again, you want to allow for swelling. Things that you'll need while you're here: inhalers, glasses, hearing aids, dentures, those things, you want to bring them. Again, we talked about day of surgery. You're going to shower with that HibaCleanse scrub. You're going to make sure to not apply any makeup, no hairstyling products, no ointments, no lotions, no deodorants. Those things are all flammable, so we want to keep them at the OR. They pose a danger to you and your surgical team, so please avoid those. Again, body piercings, jewelry, please try to remove them. Always a potential for delays. Emergencies come up, surgeries run behind, but we do a really good job with our orthopedic patients. We keep things moving. If things are delayed, we will call your family and keep them up to date as well. Things you want to do prior to coming in: prepare at home, get the house ready. Things that you use on an everyday basis, have out available to you. Think about having it chest and waist level so that you're not reaching up high or down low because your balance is going to be off. Preparing meals ahead of time, having food on hand, making extra meals, freezing them, putting them in the freezer, having a food chain, people to come out and help you or provide meals for you for a short period of time after surgery is very helpful. So if you have those things in place before, stock up on snacks high in protein. We have Ensure here at the hospital. If you want to continue with that while you're here, we just have to ask the dietitian. So this is a sample of, there are other nutritional supplements out there. Nutrition is very important after your surgery. So a lot of times patients after surgery lose their appetite, aren't very hungry, but you need to eat. Eating is very important, the protein to help you heal. So think about, stocking up with something like this, having small, frequent meals, snacks, something easy to grab. Things at home that you want to think about preparing: getting rid of scatter rugs, so clearing your pathways. Again, you're going to go home with a cane, crutches, walker, some sort of assistive device, so making sure you have nice, clear pathways. So all those scatter rugs, roll up, put aside for now. Make sure you have well-lit areas, maybe a night light for at night when you're getting up to use the bathroom, just so you can see where you're going a little better. If you have sleep apnea, you're going to bring your CPAP machine with you. Bring it in the morning of. We're going to have Biomed check it, make sure that everything is safe with that. And we want to have it available for you to use if you should need it in the recovery room once you wake up. So when you come in day of surgery, you are going to check in on the second floor. That would be the same place you checked in when you had your pre-admission testing. So when you come off the elevators, you're going to take a right. When you check in, they're going to put a name band on you. Please look at that and make sure it's correct. Make sure your name is correct, middle initial is correct, date of birth, gender, doc, all those things are very important. So please take a look at that prior to coming into surgical day. Once you have checked in, either one of the nurses or surgical aides will come out and get you and bring you back into the surgical day area where we will get you prepped and ready. So when you come in, we have you change, you put on our lovely gown and our hospital socks. The nurse is going to go over your past medical history with you. The medications, they're going to ask you the last time you had each of those medications. You don't need to bring your list with you. We have it here, but we're going to put into the system, make sure we have everything up to date. If you have started on something new between the time you talk to the nurse and the time of your surgery, make sure you bring in the name, the dose, the frequency of that medication so we can add it to your list and you can continue on that medication while you're here. Your nurse is going to insert an IV or an intravenous. Initially, it's just going to be fluids to hydrate you, but once that line is in place, you'll get your IV antibiotics, pain medication, anesthesia, everything will go through that line. Your nurse is also going to give you a little cocktail of medications. So depending upon you, your past medical history, your allergies, your surgeon is going to custom fit to you the medications he wants you to get prior to surgery. So on that list will be an IV antibiotic, a one-time dose, It could be Celebrex or ibuprofen, anti-inflammatory medication, Lyrica or gabapentin, which works on nerve pain, OxyContin, which is a long-acting pain medication, and Tylenol. So typically you're going to get some sort of cocktail of these medications. Again, your doc will pick and choose according to you, your allergies, and decide what will work best for you. You can also get a medication orally in with that little cocktail prior to something called TXA or Tranexamic Acid. It's a medication we use to decrease blood loss, decrease the need for blood transfusions. So you can either get it orally with that cocktail of pain medications, and some of you may get it through the IV in the OR, but I like to let everybody know you will get it in one form or another, and that's what we use to prevent need for transfusion, and our transfusion rate is very low here. All patients will see their surgeon. So at the time of surgery, if you have not already signed a consent in the office, you will do one with the surgeon at the bedside. They're going to use a skin marker, and they're going to put their initials on the correct side that they are working. So right knee, right hip, left hip, whichever side they are working on, they're going to put their initials with a skin marker. Any questions, concerns you have, that's the time to ask them, because after surgery, you're not going to remember anything. So if you have questions, bring a list with you. You will have time to talk to your surgeon prior to. You will meet with anesthesia. So anesthesia works as a team of two. There is a doctor, the anesthesiologist, and a CRNA, which is a certified registered nurse anesthetist, and together those two are going to work with you. They are going to go over their plan, what you're going to have, spinal versus general. A lot of times the docs do prefer the spinals if we are able to. It depends again on you, your past medical history. There are some things that could exclude you from it. So people that have neurological disorders, something like MS, that is something that we would not want to use a spinal for. If you have hardware in your back, rods in your back, sometimes that could be a deterrent for the spinals as well. If you have any open areas, rashes, anything on that back where they would be doing the spinal, that would again be another reason not to use it. If you're on anticoagulants, they would not use a spinal. Spinals are very good, they're safe, there's less chance of bleeding, less risk of blood clots, less pulmonary issues. So if you're a smoker or have respiratory diseases, spinals are more beneficial to you. But again, your surgeons will talk to you. General and spinal are both very good types of anesthesia. They both work well. So those of you who are having a shoulder replacement or a knee replacement, anesthesia is going to offer you something called a nerve block. So with a nerve block, what anesthesia does at the bedside, they have an ultrasound machine. They go to the inner thigh of whichever knee they're working on. They locate the nerve that feeds the knee, and then they'll inject a lot of numbing medication around that nerve, which helps that leg be more comfortable. For the shoulders, they use the ultrasound machine, the neck area. They find that nerve, and then they inject some numbing medication to that area as well. So the next 18 to 24 hours, you could be pain-free due to that nerve block. Anesthesia will offer you this nerve block. Like I said, it will be done at the bedside. Prior to doing that nerve block, we're going to get you up to the bathroom, have you empty your bladder. Our goal is to not use urinary catheters. Catheters are the #1 cause of hospital-acquired urinary tract infections. So we are trying to do anything we can to prevent infection. If you do have a history of incontinence or there's a need for catheter, we will use one, but typically for most patients, we are trying to not use the catheters, and usually everybody is pretty happy about that. For the hip replacements, prior to going into the OR, we will get you up and have you empty your bladder as well. But for the shoulders or the knees, if you're having that block, we're going to do it prior to that, and then the hips, we'll have you get up and go to the bathroom right before we bring you into the OR. When we do those nerve blocks at the bedside, we do something called a timeout, where we stop, we make sure we have the correct patient, the correct side, we go over your date of birth, allergies, we go through everything to make sure we have that correct. They do that again once you're in the OR. You just won't be aware of that because you'll already have some anesthesia on board. So once you have seen your surgeon, Anesthesia, you will meet the OR nurse. They're going to go over everything with you too. We repeat things a lot. There's a lot of repetition, but repetition is for safety. We want to make sure we have everything correct and know everything about you. They're going to let you know what to expect when you get into that OR. It's a very cold, bright place. We have lots of nice warm blankets. They're going to put around whatever leg they're not working on, or if you're a shoulder, they're going to put on both calves. They're going to wrap something around you called a sequential compression device. It's plugged in, it's electric, and it just periodically pumps up around the calf, and it helps keep the blood flowing, helps prevent blood clots. And then you'll have those on you pretty much the whole time while you're here in bed, and that's something we do, again, to prevent blood clots. So once you have seen your surgeon, you've seen anesthesia, you've met the OR nurse, the surgical day nurse has seen you, given you all your medications, we're going to sign you off to the OR. And anesthesia and the OR nurse are going to bring you on your stretcher into the operating room. If you haven't already gotten a little sedation, they're going to give you some on your right end to help you relax as you go in there. Once you get into the OR, they're going to have you slide from your stretcher onto the operating table. Once you're on the table, they'll do the general, the spinal, whatever it is you've decided for anesthesia. The nurses, like I said, are going to put those sequential compression devices on you. Anesthesia is going to hook you up to the monitors. Anesthesia will be sitting with you at your head the whole time while you're there, watching you, making sure your vital signs are good, that you're well anesthetized. They're going to be there watching you that whole time. Surgery time, typically an hour and a half to 2 hours. Prior to closing that incision, your surgeon is going to inject some numbing medication into that joint. So we have a multimodal pain management plan here. And the point of that is to help with your postoperative pain management. And we do a pretty good job, considering patients used to be with us for 1 to 2 weeks after surgery, and now they're going home same day and day after. So these medications, this little cocktail of medications that they inject into that joint will disperse over the next couple of days, and that's something else we do to help you be more comfortable, to get you up and moving quickly. As far as closure of the incision, once the doc is done with your surgery, the joint replacement, like I said, they'll inject that numbing medication, and then they will close your incision with either staples, skin glue, whatever their preference is, and then everybody will have a bandage over their incision. It looks like this, and this will be in place for 14 days after surgery, and the visiting nurse or visiting therapist will take this off. And you can shower with these on. They are water occlusive. Once the procedure is ended, anesthesia is going to wake you up in the operating room. At that time, the surgeon will go and call whoever you've appointed, family, friend. He'll let them know how you did, how your surgery went. At that point, anesthesia and the OR nurse will be bringing you into the PACU, post-anesthesia care unit or recovery room, where you will be for an hour or 2 hours, depending on how quickly you wake up, how comfortable you are, making sure your vital signs are stable. Again, in the recovery room, they're going to have you hooked up to monitors and be watching you closely. If you have pain, that's the time to let them know. In the recovery room, they're going to give you IV medications, which work much quicker. They have a very rapid effect. Oral medications can take up to an hour to kick in, so you really want to try to stay on top of that pain management. So we have a pain scale here, 0 to 10. Sometimes people have a hard time with that scale. We do also have a face chart that you can use as well. 0 from happy, smiling, to 10 in tears, crying. So 0 to 10, 1 to 3 mild, maybe wouldn't take anything for it. 4 to 6, it's getting worse, you need something. 7 to 10, it's bad. We anticipate pain after surgery. It'll be a different pain. It'll be a pain that will go away, but we want to make sure we manage that pain well and that you're comfortable. So again, if you have pain, please let us know. Don't wait. We're going to medicate you. We're going to ask you what your pain level is. If you tell us it's a 7, we're going to come back in a half hour, and we're going to ask you again what your pain level is. The goal of that is to see your pain level coming down. Again, it's probably not going to be a 0, but if we could get you into that 1 to 3 range, or whatever you think is a tolerable level. So that's something else we will ask you. What is a tolerable level of pain for you? Some people could be a 3, some a 4, some a 5. 5. So everybody is different. So we want to base it upon you and make sure that we keep your pain level in a range that's tolerable for you. If we medicate you because you're a 7 and then we come back in a half hour, and you're up to an 8, then we need to look at, are we not giving you the right medications? Is there something going on? So it's a tool to help us make sure that we get you good pain management. You want to think about taking your pain medications a half hour to an hour prior to therapy. So if you know you're going to be working with physical therapy, whether it's here in the hospital or once you go home, think about taking your medications prior to that. You will get a lot more out of your therapy if you're comfortable, and then you're going to ice after that. So out of the OR, in the recovery room, for the shoulders and the knees, you will have something on called a cryo cuff, which is an ice pack that will be in place. It's electric. They're fabulous. You're going to have that on pretty much all the time while you're here, and then when you go home, you're going to use it for 20 minutes every 2 hours while awake. For hip replacements, we use an ice bag. We don't have nice cuffs for you, so we fill up nice ice bags. When you go home, think about having some gel packs in your freezer. Have a couple, and you can kind of alternate. And you can alternate the sites that you have that ice pack. You can kind of move around that hip because you're going to have a lot of swelling, and the goal of the ice is to reduce swelling. If we can reduce swelling, we can help reduce your pain level. So in the recovery room, hour and a half, 2 hours, again, it depends on how quickly you wake up, how comfortable you are, how your blood pressure is, all those things. Once you have met all your goals, if you are going home same day, they're going to bring you over to surgical daycare where we'll get you ready to go home. If you're going to be admitted overnight, they will bring you to St. Mary's, which is a 20-bed unit. 16 of those rooms are private, 2 are semi-private. We do try to get patients into their own room as much as possible, but it depends on how busy we are and what our availability is. So for those patients going home same day, you will come back to us in surgical daycare. Once your spinal has worn off, we're going to call physical therapy. They're going to come and see you, evaluate you, make sure you have good strength, that you can stand, that you have an assistive device, whether it's walker, cane, crutches. If you have stairs to navigate at home, they're going to work with you on those, make sure you can go up those stairs before you go home. And then once you have done that, you're able to hold down food, fluids, you're not having nausea, vomiting, your blood pressure's good, your pain's good. We're going to call whoever you've appointed to take you home. We'll go over instructions with them, and then we'll have them come and pick you up. For those of you going to St. Mary's, the goal is to have you see physical therapy the same day as well. If it's later in the day and therapy is gone, therapy will come and see you the next day. But our goal is to get everybody up and moving same day. So if therapy has gone home, the nurses or the nurses' aides have all been trained, they will get you up. The goal is to have you sit on the edge of the bed, stand, take a few steps, get in the chair, have your evening meal, get you back to bed. Again, if you're sick, nausea, vomiting, the stars don't align, we'll get there the next day. So don't be upset, don't worry about it. Everybody always catches up in the end. When you are on St. Mary's physical therapy, if you're there a full day, typically they'll work with you 2 times during the day. Occupational therapy will see you once a day. So physical therapy works with you on exercises and ambulation, the distance that you walk. Occupational therapy works with you on activities of daily living, so bathing, grooming, dressing. They will make sure that you are able to do all those things for yourself. They have lots of equipment, so if there's things you need, they will make sure you have them prior to leaving here. Typically, oxygen will stay on overnight. Just after surgery, all the medication, anesthesia, people are pretty drowsy and tend to not take nice deep breaths, so we'll keep oxygen on you overnight. Sequential compression devices, so those little cuffs around your calves will stay on overnight as well. When you're up in the chair, and even when you go home, think about doing ankle pumps. That will help prevent blood clots as well. If your cryo cuff is not cold while you're here, please let the nurses know, because we want to keep that nice and cold. We want that joint iced to decrease that swelling. So on St. Mary's, physical therapy will be the ones to determine when you are ready to go home. They're the ones that will give you the green light. They will let case management, social worker, your nurse know, and then they will work on setting up your home care for you. If you already have an agency, they'll set you up with that agency. If you need a home care agency, again, they will find one for you. We have quite a few that are very familiar with our docs and what they like, their routines. As far as rehab, most of our patients are going home same-day surgery or day one. 80% of our patients are home day one. So that is our goal, to get you out of here. If you're not progressing, things aren't going as well, you're not able to climb the stairs that you need to be able to climb at home, at that point they might look at rehab, but again, a very small portion of our patients go to rehab. You will be evaluated for the need of an assistive device prior to going home, so walker, cane, crutches, and physical therapy will get that for you. If you need any adaptive equipment for your bathroom at home, occupational therapy will let you know what you need to get. Only your surgeons can tell you when it's okay to go back to work, when it's okay to drive, when it's okay to travel. So those are things you want to talk with your surgeon about. I also encourage patients to talk with their surgeon about if they're having any invasive procedures, dental work after having a joint replacement. Check with them regarding their preference for antibiotics, how long you need to take them as far as a prophylactic prevention of infection. Some docs like you to take it for 6 months after a joint replacement, some like you to take it for a year, some will tell you a lifetime. There is no hard and fast rule to it, so again, it depends on your surgeon and their preference. The first few nights when you go home, you want to think about setting your alarm. So that inflammatory response, especially for those knee replacements at that 48-hour mark, is when it's at the highest. So think about setting your alarm clock during the night. So if you go to bed at 9 p.m., you've taken your pain medication, you're due again at 1 a.m., set your alarm for 1 a.m., get up, take your pain medication, keep it on board. That will really help you initially. And then you can start to taper off after that. But again, that first 24, 48 hours, really stay on top of your pain medication. Again, you're going to ice the heck out of that knee. So 20 minutes every 2 hours while at home, making sure you have a protective barrier between that cuff and your skin to prevent any frostbite. When you are discharged to home, your home care agency will come to see you typically the following day. The home therapy is typically 5 to 7 visits between that first 1 and 2 weeks, and then we're trying to get you into outpatient therapy. So the goal is 2 weeks in-home therapy and then get you moving to outpatient therapy. If you find that you're not progressing, you're not moving, things are really kind of stagnating, you want to call your surgeon and let them know that you are not progressing and moving. After surgery, probably even before surgery, difficulty sleeping is very normal after having a total joint replacement, and that can be for 6 to 10 weeks post-operatively. So know that that is normal and it will get better. Typically, 50% of patients start sleeping better at about the 6-week mark. Once you go home, you're in control of your therapy. You need to get up, you need to get moving. We're not going to be there cracking the whip behind you. For those knee replacements, getting that flexion and extension in is very important. If you don't, you're going to develop scar tissue rapidly, and you might as well not have had the surgery. So you really, really need to get up, get moving, do those exercises. Again, if you're having unbearable pain, the medication isn't working, you're not progressing, you need to reach out to your surgeons and let them know. 3 main complications after surgery. So pneumonia, a very common complication after surgery. People are heavily medicated. They're very sleepy, drowsy. You're not taking nice deep breaths. So one thing we'll have you do while you're here is oftentimes, if you're admitted, you're going to have this little piece of equipment. It's called an incentive spirometer. We're going to have you do this every hour while awake, and this just helps expand the lungs. The lungs are a very nice, moist, warm, dark environment, great place for bacteria to grow. So if you're not really expanding those lungs, that's when people develop pneumonia. Some people hate this, which is okay, as long as you're doing nice, deep breathing exercises. So you really want to inhale till you feel like you can't take any more air in, and release. And you want to do that 3 to 5 times every hour while awake. So while you're watching TV, every hour when a new show comes on, think about doing your deep breathing exercises. Blood clots, another common complication after surgery. So the things we do to prevent that, we put on those sequential compression devices in the OR. You have them on in bed while you're here with us. We talked about the ankle pumps to do. You want to do those frequently. Do those every hour. So every hour when you're doing your deep breathing exercises, do your ankle pumps. Patients will go home on an aspirin regime, so 81 milligrams twice a day for 28 days after surgery is what they are using as an anticoagulant. Unless you were already on a blood thinner prior to surgery, then they will get you back on that medication. And then the third main common complication after surgery, we talked about pneumonia, blood clots. The third is infection. So the things we do to help prevent infection, we start by the screening when you come in for pre-op testing, the MRSA swab that we do. And we treat that accordingly. HIBA-Cleanse wash, which you will do night of and morning of, or the 7 days prior, depending on if you are positive for that staph. When you come in morning of surgery, we're going to do a wash to that site that you're having operated. They're going to do another wash to that site in the OR as well. So there's a lot of things we do as far as infection control. Everybody will get a one-time dose of IV antibiotics, whether it is we started in surgical day or in the OR, but it's usually a one-time dose prior to incision, and that's a preventative dose. And we do a really good job on preventing infection. We are almost 0% here at Holy Family. So something to think about too, after surgery, pain medications, decreased mobility, appetite's not great. It's very important to have a good nutritional status, even before going in for surgery, just to help with your healing process. Make sure you're eating enough protein in your meals, meats, eggs, dairy, cheese, any of those things to help increase or boost that. You can do non-animal sources, beans, lentils, peanut butter, but even think about doing those things prior to coming into surgery. After surgery, I know we talked about the Ensures that sometimes people will use because their appetite's not that great. That's something that you can kind of supplement for. Pain medication can also be very constipating, so that's another problem after surgery that we deal with. So the things we can do to help prevent that, number one, making sure you're hydrating well, increasing the fiber in your diet. Fiber can be found in whole grains such as whole wheat bread, brown rice, oatmeal, beans, all beans, pinto beans, kidney beans, black beans. So all those things you can add to your diet. Fruits, vegetables, fresh fruits, leafy greens, all those things can help with the constipation. But you also need to think about increasing your fiber. You need to increase your water intake. Otherwise, the fiber almost acts like a cement and blocks you up more. So increasing fiber and fluids after surgery will help you. But the most important for every aspect of your recovery is to get up and get moving. You need to do that to get the flexion extension, to help prevent blood clots, to help with constipation. So all those things are very important. So hopefully you found this all very helpful and you're feeling a little more well prepared for your surgery ahead. Thank you.